Start at 10 minutes time.
Okay. Hi, I'm Seita Skeen, one of the ST5 here. And can I know your name?
Yeah, I'm Prajakta, the new trainee who has just joined in the department.
Okay, nice to meet you, Prajita.
Thank
Uh,
you.
okay, Prajita, how is everything in the department? How are you?
Yeah, actually, this is my subject. I took this subject by choice, and
Okay.
I'm finding it very pleasant, happy.
Mhm.
Even the people around me are very helpful. So I just wanted to know about this perineal tear, uh,
Okay.
and that's the reason I'm taking your help.
Oh, that's very nice to hear that you're very happy in the department and appreciate your efforts of coming forward to learn about this. Any other specific reason for knowing this perineal tear repair?
Yeah, because it's one of the very common means problem
Yeah.
the patients are experiencing. So I wanted to know how these tears are classified and how we are going to repair it.
Definitely, Prajita. I'll take you through that and we'll see what types of tear are there, how to repair them, what are the principles, and how to follow up. And in the end, I'll be giving you resource material also. Okay, Prajita, can you tell me what you understand by a perineal tear till now, or have you read before it?
Yeah, actually, perineal tear are the tears which are happening to the perineum during
Okay.
labor. So they are
Yeah.
first degree, second degree, but I don't know in detail about that.
Okay, no worries. I'll let you know. First of all, there are like whenever there's a perineal tear, the patient suffers it, and once we are going to repair it, so there are some principles which you have to follow. Okay, and then in
Hmm.
assessment, I'll tell you what are the classification of perineal tear. Is that okay?
Oh, yeah, that's great.
Yeah. So once we are going to repair a perineal tear in the patient, first of all, we'll communicate to the patient, okay, check her identity, whether she's the patient which we're going to repair, as well as explain the patient what we're going to do, how much time will it take, maybe 20 minutes or 15 minutes, okay, and take the consent from the patient. All right. So
Okay.
once it is done, thereafter we'll see whether the patient is on some analgesia, like if the patient was laboring and she's on epidural, then we'll check what did the and whether she has a good analgesia and if she needs the top-up dose. Or sometimes if the patient is not epidural, then we can arrange for other type of analgesia like Etonox we have, or some local infiltration of lidocaine 1%. But we have to rule out the allergies at that moment. Okay. And also, once we are going to repair, we have to assess that good lighting is available there and the positioning of the patient is comfortable both for the patient as well as for the one who is going to repair that. Am I clear to you till now?
Oh, yeah.
Yeah, so once it's done, then we have to assess her, okay? So, and also we have to look for her vitals, what is the blood loss, okay, if already patient is not in a shock or not. So after that, we'll assess her perineal tear. We'll just systematically, swab the perineum with a sterile water swab, okay, or some antiseptic, and just inspect her, inspect her vulva and the vagina, starting anteriorly. So we have to check the periurethral area whether there are any tears, and then the vaginal wall, then the vault also, and also go for a per rectal examination because sometimes there may be some, which are not noticed, some buttonhole tears in the rectum. Okay.
Hmm.
Can you repeat one or two principles which I just mentioned to you?
Yeah, so you mentioned that regarding analgesia and regarding assessment of the type of tear, these are the two important things. And then
Yes.
verbal consent also.
Very nice. Yes, you're learning very quickly. I really appreciate that. So, after assessing, we have to assess what type of tear it is. So, we have first degree when it involves either the vaginal wall, I mean to say outer layer, that's the mucosa, or the perineal skin. Or then we have second tier when it involves the perineal muscle, like we have bulbospongioses. So, these muscles are involved. And third degree is when there is the anal sphincter muscle involvement. And that we have 3A, 3B, and 3C. 3A is when the external anal sphincter is involved, but it's less than 50%. Okay. And
Yes.
three Bs when it's more than 50% external anal sphincter involvement, and three Cs when there is the internal anal sphincter injury. And fourth grade is when there is the anal mucosa or rectal mucosa is involved. Okay.
And what is type 1 and type 2?
Yeah, type 1 is when there is the only lacerations involving the vaginal mucosa or the perineal skin. And type 2 is when, in addition to this, there is the, perineal muscles are involved. Okay.
Oh, yeah. Good.
Is it clear? Yeah, yeah, nice.
Yes.
So after that, once you're going to repair it, let me show you on this. Okay, like I can draw it also for you. So once you're going to start to repair it, the important point is that you have to notice the apex, okay, of the let's see, we're repairing episiotomy. So we have to assess where is the apex because it's very important. We have to go 0.5 centimeter above this and not to go more deep because there can be the rectal mucosal involvement. Okay.
Yeah.
So the type of suture mostly we recommend, Vical Rapid, you have 30 or 20, you can use it and just take 0.15 centimeter bite above the apex and then start suturing the vaginal mucosa in a continuous
Type of suture material, Vicryl, which number of Vicryl we should take? You told me?
we can, yeah, you can take 2O, okay?
Okay.
Yeah. So that is absorbable suture, and we had to start zero point 0.5 centimeter above and then continue in a continuous non-locking manner, like I'll show you here. And the bite should be, it should be 0.5 centimeter apart. Okay, and take one 0.5 centimeter from the edge and 1 centimeter apart. Is it clear so far, Rajita?
Okay. Yeah.
Yeah. So you have to keep alignment properly, like you have to look after where is the hymenal ring so as not to cause any disfigurement to the patient. And once you reach the introitus, then you have to introduce the needle through the muscle and then continue stitching the muscle in a continuous non-locking manner. Okay.
Hmm.
So during this, you have to be sure that there are no bleeders and there is no hematoma. Okay, so as to have a proper hemostasis. Then about the perineal skin, you can suture it either a subcuticular, you can use the subcuticular continuous sutures or sometimes the intraocular sutures may be used. Am I clear to you so far?
Yeah. Quite clear.
Yes.
Quite.
So this is, yeah. So once we stage them, then we have to ensure whether the hemostasis is there proper, and we can also then swab the perineum for cleaning, as well as we after ruling out the allergies, we can offer analgesics to the patient in the form of per rectal dose or orally the patient can take it. After that, we had to ensure the patient shift to the ward and or document everything what we have done, what type of suture we have used, and in the follow up, like we have to ensure that we have documented everything and ensure a discharge plan for the patient. And one thing is that we have to explain to the patient about the red flag signs. Okay.
Oh, yeah. Quite clear.
So, yeah, if the patient has develops like some severe pain which is not controlled by analgesics or some swelling and some type of discharge, foul smelling discharge, fever, then she has to report to us immediately or to a special clinic, that's the perineal clinic. Okay,
Yeah. Quite clear.
okay. And do you have any questions, Prajita, or you want me to repeat something?
No, it was quite clear actually. You
Mm-hmm.
had explained me very nicely. Um, do you need to involve someone while repairing? Do we need to have someone with us?
Yes, we need to have an assistant, like who can give us any instruments we need or any suture material we need. And also, after assessing, if we are suspicious that we're not able to assess it properly, then we may involve our seniors to assess the tear appropriately so as to have a proper stitching. Okay.
Okay. Okay.
Yeah. So, Prajita, can you tell me how was the session?
Oh yeah, it was wonderful session. I could able to learn so many things about this perineal tear, especially the classification and how to
Mm-hmm.
repair it. Yeah, so I will whenever there will be any tear next time, I will definitely come and assist you and would like to perform this procedure uh, after that.
Yeah, that's so nice. I'll be very much, I'll be much happy to help you. And in any case of any difficulty, you can come to us. I'll give you some resource material also. Also, we have a videos on strategy. You can go through them, and you can also practice on some dummies and drills so that you may be able to do it comfortably. Okay.
Thank you.
Thank you. Thank you for your time. Have a nice day.
Wonderfully done. Wonderfully done. Anybody wants to comment on her performance? Means if you think that she has missed on this and something on that. Anybody? Anyone can come up and give some feedback, some good words, some bad words. Anything is okay with me.
I think station went on very beautifully. Only one thing I felt ki maybe do we have to say, it's not like comment on her. I'm just asking from my side. Do we have to tell that you may have to observe few more what you say, few more procedures? Then maybe you can do
Yeah,
it
you
under
can say.
supervision.
Yeah, you can say the way I said now that I will
Yeah,
be coming
last
and
closing.
assisting you. Yeah, so you can say
Yes.
that. Okay, yeah. So this is means prior to you need to assist, observe, assist, and then you can do it individually. Yeah, you can say that sentence. But in the answer key of this book, it was not mentioned. But in RCOG exam, you can say. No worries. If they and especially if they had asked you to make a educational plan for the trainee, then in that case, these are the sentences which you are going to say.
Okay, thank you, ma'am.
Okay. Anybody else wanted to ask anything? Okay. Any other word? Means wonderfully done. Okay. Wonderfully done, Dr. Taskin, as always. Uh, my answer key is also involving the same thing. So introduction, rapport building, rule out bullying, checking teaching domain. So what I wanted to know, you asked me. What I know, you asked me, and what are the objective of session. So goals and objective basically. Here I wanted to know about type of tear and repair. Post procedural follow up. Okay. Pre procedural also, if you can include, you can include here. 2 3 points are there which you, if we can say, it will be better off. um Appreciated, you appreciated the trainee, and at the end of the discussion, when the trainee will be aware about or understand the principles of the repair of episiotomy. Repair of episiotomy, assess the patients and safety of the patient. Okay. First upon, once the episiotomy or perineal tear will be there, you need to assess and type the tear, whether it is type 1, type 2, 3, or 4. So, PR is very important prior to the procedure. Local examination, per speculum, per vaginal examination, and if needed, PR examination to rule out any buttonhole tear. Very important, which you said. Then here also you can explain me the type of tear, or I have mentioned in the next slide. uh you can ask, this question was missed by you, Taskin. Have you done,
Yes, ma'am.
observed, yeah, have you done or observed any episiotomy repair previously?
Okay, yes, we can
Yeah.
ask that.
Yeah, so this one question can be asked. So you asked me why I am interested in learning this skill, but this question is also very important, whether I have done, asked, the seen, observed previously. So that
Mm-hmm.
can be also. Once identify, we need to introduce yourself to the patient and explain to the patient what you are going to do, and for that we are going to require a verbal consent which needs to be documented in the case paper. Analgesia is very important. Analgesia because it's painful to suture it without anesthesia. So either local infiltration, Antonox, perineal, pudendal block, or epidural if the patient is on that. So top up might be required here. Ensure good lighting. Hmm? Good lighting will be available, and the patient's position. Here I had, this is my second slide where I had just mentioned regarding the type of tear. So everybody is very clear regarding the type of tear. First, second, third, fourth. She has explained very nicely. Then preparation prior to procedure. What is required here? So we need to have a episiotomy trolley needs to be prepared by the nursing assistant or midwife who will be assisting us, where it will be adequate equipment, swab needle count, swab needle, uh, suture material and needle holder, and analgesia if needed for local infiltration, syringe and needle. So you can set these points also, and then how to repair. Under all aseptic precautions, proper exposure needs to be given. Repair needs to be done by a trained personnel. Anesthesia is not actually anesthesia, it's analgesia is needed here. Active management of third stage of labor, you missed out.
Yes, yes, ma'am.
Yeah, okay, this point you missed out, and there might be some trickle which will be coming up from the
Mm-hmm.
vagina. So how you are going to do ensure that there will not be any trickle? So here you can take a help of any assistant to show you the apex. And another point is you can take a some vaginal pack or vaginal pack basically, which you can introduce into the vagina, so that there will not be any bleeding from the cervical walls. So the visualization of apex will be proper. Identify the apex. Very nicely you mentioned 0.5 to 1 centimeter above the apex, not too deep, so that avoid injury to the rectal mucosa or rectum. Then 0.5 centimeter away from the edges, and 0.5 to 1 centimeter at a distance which will be non-interlocking, continuous non-interlocking. 10, actually here actually they had mentioned 20 vicryl or propylglycol, but in the RCOG they mentioned 10 vicryl, or even that basic practical skill book also mentioned 10. Just
Okay.
check it. Okay, just check it.
Mhm.
So 10, 20, or you can say whatever the unit is using. Some might be using 10, some might be using 20. So I had mentioned here 10 also, 20 also. Uh, Edges 0.5 centimeter, 1 centimeter apart and 1 centimeter deep. Ensure that you will not injure any blood vessel. Hemostasis will be achieved. Uh, Bring those mucosal approximation till the hymenal ring, and then go back to take a muscular ring. Okay, muscle layers. Again, same, continuous non-locking sutures. And lastly, it will be a skin. So either subcutaneous, or the next will be matrix suture. Subcutaneous sutures are better off because they are less painful. Here, another important point is, once completed, check the vagina that you have not tightened the vaginal hymen too tightly. Okay, so at least 2-finger PV should be possible with ease. Again, perform rectal examination. This you had missed actually. Did you missed
Yes,
it?
ma'am.
Yeah,
Yes,
so
yes.
this is my safety point here. That's the reason I had mentioned it on red. Okay, so perform rectal examination to see whether there are any rectal penetration, mucosal penetration by the suture. Diclofenac suppository you mentioned. Swab needle count, we need to ensure that it will be adequate. Uh, with second person, that person can take a swab instrument count, recording the findings on the clinical data collection system or documentation, what we can say. Resources you mentioned, feedback for teaching you mentioned. The last point I've just forgot to add actually, the post procedural care, what you need to tell. So the post procedural care, we need to tell to the patient that this is painful, what are the signs and symptoms she needs to follow. It should not be, there should not be excessive pain, excessive bleeding. It might be any vaginal wall bleeder or apical hematoma. Thirdly, bladder urinary retention. It's very common in this patient. So urinary retention. So bladder care is very important. First, keep a watch on first void. If any signs of retention, report back. And once the patient will be discharged home, any abnormal vaginal discharge, foul smelling, bleeding, bleeding, patient needs to be reported back, or any problem with the healing of the wound. So she can be report to the GP services, perineal clinic. She can be report. Okay. So this way, it was a wonderful topic what you have done. The way you had presented also was very good. So coming to the scoring on this patient, on this case, information gathering, Okay, no, this is not the information gathering. So I think I have not included in my answer key here information gathering. St- You can open a book. So once, if you wanted to see the information gathering will be in this domain. Uh, Communication with colleagues, state the objective of teaching and what the outcome of the exercises will ascertain. If the trainee has repair before and their expertise experience with repairs, which you had missed dear. Elaborate, explain the principles involved in the perineal repair, which you had explained very nicely. Different types of tiers, requirements for understanding a repair are also you explain me. Take the trainee in stepwise manner through repair of the perineal tear, you had taken me. And one more point, if it you are doing in the real exam, if they are saying that you are doing on this case Mrs. ABC, so in that case do not give your trainee a hands-on training. If you are doing on a patient, in that case, so here you need to
Okay.
explain to the patient, this is a patient, so patient needs means the person who is experienced enough should be doing in that patient. But if you are
Mm.
doing on a mannequin, if you are doing on a mannequin, please ensure you will give at least hands on to the training. Okay,
Okay.
if you are teaching that, here they had not mentioned whether it was a mannequin or whether it was a patient. So in that case, ensure that if it is a mannequin, you are going to give hands on to the trainee. There you might require 30 seconds to 1 minute, and he might be doing one or the two steps means in a wrong fashion or a wrong manner. Identify without hurting his or her sentiments and correct it. That is also a patient safety. He might be missing a apex or something like that, or he might be not following under all aseptic precaution, what we used to say na, under all aseptic precaution. So what we have seen RCOG exam courses, the trainee is not keen on maintaining the asepsis. So after wearing the gloves, he touches here and there. So these are the points which you have to be very keen what he is doing right and what he is not doing rightly. So identifying that thing is very important. Take the trainee stepwise manner through the perineal repair as done. Discuss the indications for referral to senior for repair. Here we do not need basically. Okay. Communication with patient and families. Explain patient what we are going to do, which you had explained, and obtain consent. Adequate analgesia and duration of repair and course of the recovery. What we need to tell her. Patient safety. Ensure the trainee understand the risk of improperly repaired perineal tear. Confirm patient details before embarking on the procedure. Minimize complication from anesthesia, provide the right dose of anesthesia. Steps to identify and deal with the complication of the repair. Teaching should be show that the steps have been taken to minimize the long-term consequences of repair, especially related to subsequent pregnancies. Applied clinical knowledge, principles, different type of perineal tear, that is classification. Justify the use of instruments. Okay, so what instruments you are going to use? So that might be there as a props. Please ensure you will use the specific instrument. Take in your hand and show it in a proper way. Justify checking procedure after successful repair, uh, and the knowledge about the green top guidelines. So here there is no knowledge on this part. So overall you have done a wonderful job. Anybody is having
Thank
any
you.
question? No. Thank you.